Good evening, everyone. Last week we saw about the introduction to reconstructive microsurgery, and today we'll go into real hand surgery. And one of the commonest problems that we come across in hand surgery is the median nerve palsy. Even though we see cases quite often, there are some questions in our mind regarding certain points about the median nerve palsy, which we will try to sort out today. And of course, the usual, right? Okay, so today the agenda is going to be about the median nerve palsy. We'll start off with the anatomy of the median nerve, the surgical anatomy. What is important for the surgeon from the surgeon's point of view, the causes of median nerve palsy, and clinical examination. How to do a correct clinical examination of a patient with a median nerve palsy, and decision making. This is one of the most important things. You may do a good clinical examination, but at the end, you have to make a decision. And that we'll go through the process of that. And of course, we'll have discussion. This time, we'll have discussion of two cases. One which we discussed on WhatsApp and on Learning General Surgery yesterday and today. And of course, the quiz question of the day. Now, the median nerve, as I said, we'll talk about the anatomy, the causes of palsy, the clinical examination. There are only 4 points we're going to discuss about it. The remaining we'll be discussing in the next session. Now, the anatomy, we need to remember that the median nerve is formed by the medial and the lateral roots. The lateral root from the lateral cord of the brachial plexus and the medial root from the medial cord. One thing we need to remember, the lateral root has got a root value of C5, 6, 7, and the medial root has a root value of C8, T1. And what is coming in the lateral root is mainly the sensory fibers to the median nerve. So the sensation on the radial aspect of the hand, the 3.5 fingers, is mainly coming from C5, 6, and 7 roots. And the C8T1, the medial root, is mainly contributing to the motor function. As far as the topography, the arrangement of the sensory fibers and the motor fibers in the arm is concerned, we all know that there are no branches in the arm for the median nerve. The entirety is mixed fibers in the proximal portion. As we go distally, we find that the motor fibers become a little more anterior, and the mixed fibers and central portion and the anterior interosseous nerve, the branches that are destined to go to the anterior interosseous nerve, are more in the posterior portion. At the elbow level, it is mixed in the upper half, and the lower half, it is mostly motor. So the deeper portion mainly contains the motor fibers. As the median nerve enters the elbow, it gives off the branches to the common flexor origin. That is, it supplies the flexor carpi radialis, the palmaris longus, the flexor digitorum superficialis, and the pronator teres. These 4 muscles are supplied as soon as the median nerve enters the forearm, crosses the elbow and enters the forearm. Then it gives off the deep branch, that is the anterior interosseous nerve, which supplies the flexor digitorum profundus of the index and middle fingers, and supplies the flexor pollicis longus, then supplies the pronator quadratus. The rest of the median nerve proceeds distally and gives off palmar cutaneous branch just proximal to the wrist, and then supplies the hand. At this level, at the point of the distal forearm, it is very important because the fibers, the motor fibers are more anterolateral, and the sensory form the rest of the fibers. In the hand, of course, we know it enters the hand through the carpal tunnel. Once it enters the hand, it gives off the recurrent branch, and then it gives off the lateral and medial division. The lateral division may give off the recurrent branch, and then we have the sensory branches to the thumb, index, mid, and the radial aspect of the ring finger. It also supplies the muscles commonly known as the lobe muscles. The first and second lumbricals, which are usually unipinnate. Then it supplies the opponens pollicis, then abductor pollicis brevis, and then the flexor pollicis brevis, which has 2 heads, the superficial head and the deep head. The deep head may be supplied by the ulnar nerve. And of course, the sensation, cutaneous sensation, supplies the radial 3.5 fingers, that is the thumb, index, and mid finger, and half of the ring finger. Now, anatomic variations, we have all heard of the Martin-Gruber anastomosis, that is the communicating nerve branch between the median nerve and the ulnar nerve. There are actually 3 types of Martin-Gruber anastomosis. And it is a most common variation in the upper limb, occurs in about 15% of the patients. It carries only motor fibers. The first type is from the median nerve to the ulnar nerve, from the main median nerve, that is after the anterior interosseous nerve is given off, from the median to the ulnar, and the 1B is from the anterior interosseous nerve to the ulnar nerve. The second is type 2 is anastomosis between the FDS branch to the ulnar nerve, and type 3 can be a combination of the above. Now, the important thing, significant point is, sometimes if there is a problem with the anterior interosseous nerve, there is an injury to the anterior interosseous nerve, and there is a type 1B Martin-Gruber communication. We know that it is an anterior interosseous nerve palsy, but still we will find some weakness of the intrinsic muscles of the hand, like the palmar and dorsal interosseae. This may be a little confusing, because we know that the ulnar nerve has not been injured, but this will explain why we find sometimes the paralysis or weakness of the ulnar supplied nerves in a case of pure median nerve palsy. Now, we will now see what are the main causes of median nerve palsy. Injuries to the median nerve form the biggest component. Next, we have compression syndromes, then Hansen's, then lesions in the axilla, which we shall be seeing now. Now, injuries to the median nerve form the major component. It could be high up in the elbow, sometimes even in the arm or in the axilla. And here you can see that there is an injury to the median nerve. This was an example that I quoted in one of my talks earlier on. The next is, it could be at a lower level at the wrist. This is injury. This is sometimes called the spaghetti wrist. That is, all the tendons are cut and the median nerve is cut. There are 2 types of injury to the wrist, common patterns. One is a superficial injury where the flexor carpi radialis, the palmaris longus, and the median nerve are injured. This is called the radial triad. Sometimes what happens when there is an assault injury and the patient tries to protect himself, the injury occurs on the ulnar border. This is called the ulnar triad. Here, the flexor carpi ulnaris tendon, the ulnar artery, and the ulnar nerve are injured. So these are 2 common patterns, but there is another injury called the spaghetti wrist, where all the tendons are cut at this level and the median nerve, being just deep to the palmaris longus, is also injured. The second is, after injuries, the second commonest is compression syndrome. We have got the 3 important syndromes as far as the median nerve is concerned. The pronator syndrome, the anterior interosseous nerve syndrome, otherwise known as the Kilonevin syndrome, and the carpal tunnel syndrome, which is quite common. Now, this is the anatomy at the level of the elbow. You will find that the pronator teres muscle is the most radial in the group of muscles. So that may cause a compression of the, so the main areas where the compression occurs could be the pronator teres. Second could be the arch of the flexor digitorum superficialis, under which the median nerve goes. And third is the bicipital aponeurosis, which may sometimes form a sharp edge and compression of the median nerve. And lastly is the ligament of Struthers. Now, this ligament of Struthers is actually a ligament that extends from a bony protuberance here. Now, in animals, in apes, this is actually a foramen through which the median nerve and brachial artery come. But in the evolution, this has become a ligament. This may sometimes cause a compression. Then lastly, the anterior interosseous syndrome. This is mainly a motor nerve. So we have a problem affecting the muscle supplied by the anterior interosseous nerve, that is the flexor pollicis longus and the flexor digitorum profundus of the index and mid fingers. And lastly, the carpal tunnel syndrome, where there is weakness patients will complain mainly of loss of sensation and weakness of the hand. If it is in the delayed case, the patient may have some problem of movements of the muscles of the thumb. You can see the thinning out of the median nerve when exploration is done. Next, we have got Hansen's disease. In our country, Hansen's is still seen. We are still seeing patients with Hansen's. In a case of Hansen's disease, the involvement of the median nerve is usually a low median involvement, whereas the ulnar nerve is involved at the elbow, so it is a high ulnar and low median. You can see in this patient, you can see the typical simian thumb or ape thumb. Though we are not supposed to use such terms, you can see the flattening of the thenar eminence and the position of the thumb, which has become supinated now. The thumb should normally be facing this side or pronated. Here it is totally supinated. And you can see the movement, you can see the deficit, motor deficit here when he tries to oppose. We shall see more about this action of opposition. And lastly, lesions in the axilla. Median nerve can be involved by tumors also. Like for instance, this girl who had a swelling, you can make out the swelling over here. She had a swelling, and we did an FNAC and found it was a rhabdomyosarcoma. We explored and found, now this, you will find that this girl has got a median nerve palsy, typical features. Now look at that. They usually use the other fingers to flex the index finger. You can make out that the flexor pollicis longus is not active because this is the case of a high median nerve palsy. Now we'll go into the clinical examination. Now, what we need to see when we assess a patient with a median nerve palsy are, sometimes the diagnosis may be very obvious. He has got a flattening of the palm, the thumb is supinated, the thenar eminence is sort of flattened out. There is a low wasting. But what we need to see, the attitude of the hand, if there any scars are present, look for trophic ulcers, and then look for any deformity of the thumb and thenar wasting. Then the test that we do, we'll see that as we go along, and the muscle testing of the different muscles, especially the flexor digitorum profundus, flexor digitorum superficialis. Now, before that, I just wanted to explain about what is this movement of opposition. Now, we always say thumb is very specific. It's got a movement of opposition. What is opposition actually? Opposition is actually a sum of three movements. One is abduction, that is palmar abduction. Second is flexion, and third is pronation. So here, this is abduction. Then it goes in for flexion. Then you can see the thumb is turned. So it goes in for pronation to cause a pulp to pulp pinch. This is called the tip to tip pinch. This is not ideal. We are supposed to get a pulp to pulp pinch. This is called a pulp to side pinch. This is otherwise called as a key pinch. This is also not a good sign in the sense that it is a good, important, one of the types of pinch that is required. But in a median nerve palsy, we should assess the pulp to pulp pinch. We'll be seeing that again. Now, to get this opposition movement, there are three important muscles: the abductor pollicis brevis, the opponens pollicis, and the flexor pollicis brevis. And among these three, two are supplied by the median nerve, that is abductor pollicis brevis and the opponens pollicis, and the flexor pollicis brevis is supplied by both, as we have seen. So, what is the problem? This is not acting, this is not acting, this may be acting. So, what we have is, when there is a pure median nerve palsy at a lower level, we have only flexion, and the patient is trying to do the opposition with only flexion. Now, examining, first we will now look at this patient. He's got only this much. Only this is the scar, but he has got a median nerve palsy. So now we will examine the hand. He will find that there is a wasting. Look at the thenar wasting. You can make out the thenar wasting here. Then we check for the pronator teens.
Yes,
this is an injury in the level of the.
Next.
Then next we check the flexor cartilage.
You're checking what? Flexor again, this is
now
very
here,
good. You can see the tendon there.
Yeah,
okay.
That is the flexor cartilage. Now you check the palmaris longus.
Yes.
You oppose the thumb and the little finger and flex the wrist against resistance. Then test the FDS of
feel the
the
tension of
index.
the.
Now we test the index finger, FDS. Whenever we check the flexor distance superficial, now the O sign for the FDP of the index. A patient with the intact median nerve should be able to make the O sign like this. Sometimes if the median nerve is involved, it will collapse like this. He will not be able to make a perfect O. Now we have to check the FPL. Now the FPL is checked by supporting the proximal phalangeal region, and patient is asked to flex the IP joint. Now the pen test for abduction. Patient, first it must be demonstrated on the normal hand. We must ask him to palmar abduction of the thumb and then ask him to touch the pen which you are holding parallel to the palm. After demonstrating on the normal hand, we should ask the patient to do it on the affected hand. While the patient is doing it, he may attempt to do it even if the median nerve is paralyzed. I told you the other flexor, that is the flexor pollicis brevis, may act. So what we need to do is we need to check the tone of the muscle. That is the second part of the test. First is he should be able to touch the pen, and second is we should also palpate and check the tone of the muscle. The abductor pollicis brevis muscle is the first muscle that is volar to the metacarpal bone. You can palpate the metacarpal bone here, and you can feel the bulge of the muscle here. So now you have to, that is a normal hand. Now this is the involved hand. You can make out the wasting also. In this place, there is a wasting here. You have to feel the tone of the muscle. If it is not, see now it looks like he is doing opposition. But this is not opposition because he is using flexor. And we know that because we are able to palpate this and find that there is no tone there of the abductor pollicis brevis. Next, we need to check the opposition. When we check the opposition, I told you we need to check the pulp to pulp pinch. This is the ideal position in which to check for the opposition of the thumb. And there is a different grading for this. You are able to touch, if patient is able to touch till this crease or till this crease, it is complete. Now this is the case of high median nerve palsy. Patient is not able to flex the index finger. Patient is doing it with the middle finger. So now patient, and there is a loss of flexion at the interphalangeal joint. You can make out the extended IP joint here. You can make out the loss of tone in the abductor pollicis brevis. You can make out the wasting. Now I'm checking the flexor digitum superficialis. When I hold the other fingers like this, patient is not able to flex. So these three, since the index, the middle ring and little fingers, the FDPs are together, we prevent the FDP from acting. Now just look at this. You will find that the patient is not able to flex the proximal interphalangeal joint. Even if the patient flexes the proximal interphalangeal joint, we need to check the tone of the distal interphalangeal joint. Sometimes they use their FDP, even though you are preventing it from acting, they use the FDP to try to flex the PIP joint. So there will be an increased tone in the distal interphalangeal joint. This should also be. So whenever you check for the median nerve palsy, one is the visual, you're looking at the movement. Second is we need to palpate to confirm the finding. So this is a case of no median nerve palsy. Now look at that position. He is not able to do pulp to pulp. He is only able to do to the side or the tip. The thumb is not, and look at the amount of flexion that is occurring here. This shows that is the flexor pollicis brevis. So next time you come across a patient with a median nerve palsy and ask him to do an opposition, just because he is able to touch the ring finger, he is able to touch the little finger with the thumb, it does not mean it is opposition. Pulp to pulp, palpate for the tone of the abductor pollicis brevis, and also look at the acute flexion in the metacarpophalangeal joint, which is a clue, which is a giveaway sign that it is not the median nerve that is intact. Now we come to the decision making. Now we need to localize the level of the lesion and then take a decision about the management. Now, about localizing the level of the lesion, this can be done by finding out which muscles are involved. For instance, in a low level lesion, the abductor pollicis brevis, opponens pollicis, half the FPB, lumbricals 1 and 2 are lost and the sensation is lost because the injury is occurring somewhere over here. So all these muscles, the muscles supplying, the loaf muscles are paralyzed and there is a loss of sensation on the thumb, index, mid and ring fingers, half of the ring fingers. When you're checking for sensation, we should be able to ask the patient. As I said the other day, when you are checking for sensation, we can ask a leading question. We can ask them whether they have any sensation, whether they have altered sensation. They will definitely tell us if that there is a little bit of numbness in that area. Then next is, this is the low level lesion. Now, high level lesion above the elbow, here I told you as soon as the nerve enters the forearm, that is, it crosses the elbow, it gives off branches to the pronator teres, the palmaris longus, the flexor carpi radialis, the flexor digitum superficialis of all fingers, and the other muscles supplied by the anterior interosseous nerve, that is the FDP of the index and mid finger and the FPL. So that level you will have all the muscles being paralyzed and loss of sensation on the thumb, index, mid fingers and loss of sensation on the thenar area. Remember, the thenar area is supplied by the palmar cutaneous branch, which is given off about 2 or 3 centimeters proximal to the wrist, and this is also paralyzed in a high level lesion. Whereas in a low level lesion closer to the wrist, this nerve might escape. And this is in the proximal forearm. Here, the injury, when the injury occurs distal to the nerves that are given off to the FDS, given off to the flexor carpi radialis, and the nerve given off to the pronator teres, we have what is known as the involvement of the flexor digitum profundus of the index mid fingers, FPL, pronator quadratus, and all low levels, that is, the loaf muscles are all involved. Now, the decision making. Once we have identified the lesion and found that it is either high or low or medial or in the middle of the forearm, we have now found out where the lesion is. This decision would be taken either in an acute injury where you can see the wound, or in a case of a compression neuropathy, or in a case of a tumor where the tumor can be identified, or in a case of a Hansen's. In a Hansen's too, we will be able to find out where the problem is. Now, when we come to the decision making, the investigations have to be done. The investigations for a case of median nerve palsy include a nerve conduction study and of course an X-ray, the basic investigations, and a nerve conduction study is more specific. Next, when we come to surgical management, there are only few surgeries possible in a case of median nerve palsy. The first surgery is exploration. We need to explore whether it is an open wound or a compression neuropathy, or it is a Hansen's disease, or it is a tumor. We need to explore. The exploration will give us an idea about what the actual lesion is, and then it will take us to the next step of decision making, which will be to do a nerve repair. A nerve repair can be done primarily. A repair means you are just suturing the ends together. That is repair. If you are not able to suture the ends together, it becomes a reconstruction. In a repair, we need to see, it is not always, supposing it is a primary injury and it is a cut injury, you will find that both the ends are together, you can comfortably do a repair. Supposing it is a crush injury and one segment of the nerve is involved, then you have a problem because there is a gap. Similarly, when you are exploring an injury after a few days or after some months, there is a proximal neuroma and a distal glioma which we have to excise to get back to normal looking nerve, so that we can do a repair. Again, there would be a gap. Now, can we pull the nerve ends and suture them? That is the decision to be taken. Generally, up to 2.5 centimeters of gap in the median nerve can be bridged primarily. You can mobilize the nerve proximally and distally and suture it. We must remember not to flex the wrist too much and do the suturing. It will definitely give way. And putting the wrist into acute flexion is not ideal. So here you can do a nerve repair if it is clean cut or if there is a gap of less than 2.5 centimeters. If the gap is more than 2.5 centimeters, we need to do a nerve reconstruction. Now the nerve reconstruction consists of two types. It could be a nerve grafting or a nerve transfer. One of these two. So when do you do a nerve grafting? When do you do a nerve transfer? Nerve grafting is usually done in the early stages. That is, if it is going to be within 2 years, I mean even 2 years is a little too much. Within 1.5 to 2 years it can be done, or because the motor neurotization of the muscles must be done before 1.5 years. Beyond that, what happens? The motor end plates are degenerated. There is no point in doing a repair because the nerves will not be able to neurotize those muscles again. So there, if you're doing it within that period, you can do a nerve grafting, which can be either vascularized or non-vascularized. If it is more than 2 years, still there is a role for nerve grafting because the sensation at least can be achieved. And these are important fingers, and sensation of these fingers must be achieved. So at least for the sensation, nerve grafting can be done. So when do we do a non-vascularized nerve graft? When do we do a vascularized nerve graft? We do a non-vascularized nerve graft when the gap is less than about 6 centimeters. If it is more than 6 centimeters, generally we don't do a non-vascularized nerve graft. It is preferable to do a vascularized nerve graft. So if we have a good proximal stump and a good distal stump, a nerve grafting is ideal for sensation. But beyond 2 years, it is not ideal to do just a nerve grafting. We may have to do what is known as a nerve transfer. Nerve transfer is something to achieve a growth into the nerve from some other nerve. It can be done either proximally or distally. For instance, if there is an injury in the brachial plexus and the median nerve, we know that the median nerve has formed from the medial and lateral roots. And supposing there is an injury of the lateral cord and the medial cord, so naturally the median nerve is going to be affected. So you can transfer some nerve which is intact and without causing any deficit, permanent deficit to some other area. We can take the nerves, for instance, we can take the intercostal nerves. Multiple intercostal nerves can be used to transfer. Similarly, when you're doing it on the forearm, distal forearm, also distal nerve transfers can be done, which we will deal with in detail in the next week. Similarly, however, there are some situations when you may not be able to do all this because the patient has presented late. Patient has come to you after 2 years of the injury, or a repair and reconstruction have been done, but it is not acting. So now you need to get back the movements so that his thumb can act normally. Now it is not possible to do it with a nerve reconstruction, so we need to go for what is known as a tendon transfer. This again we shall see in detail in the next session. With all these methods, there should always be an element of supportive treatment, application of correct splints, application of electrical therapy, stimulation, nerve stimulation, application of mobilization, active and passive mobilization to keep the muscles intact. That is, the neuromuscular junctions must be kept intact and the muscles must be prevented from going in for contracture. So supportive therapy is very important. Now we have seen the anatomy of the median nerve, the causes of injury of the median nerve, causes of median nerve palsy. Then we have seen the other reasons, the decision making, and we have also seen in detail about the clinical exam, the basic clinical examination of median nerve injury. So now we will continue with this in the next session on median nerve palsy and surgical management. Right now, we will now finish the two case discussions. The first case which was widely discussed was this patient who had an amputation of the thumb and index finger. Now, the questions were, what will be your composite plan, and specify the probable time schedule also. With every stage, what are the complications you can expect? And third is, when counseling the patient, what are the minimum 5 points that should be emphasized? Now, this is an amputation of the thumb. And as you know, the movements of this hand, the function of this hand is affected by about 40%. There is a 40% deficit in the function. So now when you analyze this problem, there are certain basic things that we need to see. First is, there is a loss of thumb at the level of the CMC joint that we could see from the X-ray also. Second, there is a loss of index at the metacarpophalangeal joint of the thumb. Important point to remember and note down in our recording is, three remaining fingers are functioning well. This should also be kept in our mind. Then it is a right hand, it is a young patient. And lastly, what do we need? Now, what do we need? We need a full length of thumb. Okay, that is decided. Then, what about the CMC joint? There is no CMC joint there. So what do we do if you're going to give a thumb? If you're going to give a thumb, we can do it in two ways. Whenever there is an amputation at the level of the CMC joint, either you can do a polycization, which will give you a moving CMC joint, because when we polycize the index finger, usually the index finger is polycized. When the entire index finger is polycized, the metacarpophalangeal joint of the index finger becomes the carpometacarpal joint of the thumb. But here there is no index finger, so the polycization of the index finger is out of question, and polycization of the other fingers which are functioning is also not ideal. So if there is no CMC joint and we are not able to give a CMC joint, we need to plan for a fixed CMC joint. We cannot provide movement unless we do a vascularized metatarsophalangeal joint transfer, which is a little remote, that can also be thought of. Next is transmetatarsal. Now we need to give the full length of thumb. That can be done with a transmetatarsal second toe transfer or a trimmed toe transfer. Now the trimmed toe transfer takes from the big toe, and the transmetatarsal second toe transfer obviously is from the second toe. But it needs a groin flap. Now the toe transfers that we are planning for. Now, when you have a problem like this, where there are only 3 fingers of a 5-fingered hand, we need to try to add on rather than subtract. So polycization is a technique where you subtract. We want to add on here rather than subtract. So a toe transfer is ideal, but we need to give a groin flap because the toe will not bring enough skin. So a groin flap beforehand is ideal. Now, what about that second metacarpal bone that is there? It seems to be redundant. Can we utilize that? Is it possible? Now, utilizing that bone for transfer, vascularized transfer can be done to the thumb, on top of which a toe transfer can be done. But there are certain advantages and disadvantages of taking the second metacarpal bone. First, the advantage is you are utilizing that bit of bone as a vascularized tissue to reduce the need for to reduce the length of the toe that you're taking. But there is a disadvantage in that the width of the palm is going to get narrowed. It is important that you maintain the width of the palm. So these are the points for arguing for and against using the second metacarpal bone. And what about cosmesis? You will find that if you do a groin flap and a second toe transfer, this deformity on the index finger, the lack of the index finger, may be a cosmetic problem. And secondly, it may also be a functional problem, because the thumb web may be narrowed. So it is ideal. You can even do a ray amputation of the index finger and make it look in the shape, will come in this shape, so that you will have a good hand, that the functioning hand that looks good with a fixed thumb post. So the composite plan and time schedule would be as follows, in my opinion. First is tubed groin flap cover. Second stage would be a flap division and inset at the end of 2 to 3 weeks. Stage 3 would be a transmetatarsal second toe transfer and fix the metatarsal to the radius and and give a fixed radial post. He already has a good complete length functioning ulnar post. And stage 4, I would assess the new thumb web and do a ray excision of the second metacarpal. The complications I would like to think about are delay due to infections in my stage. This is my roadmap. Now, failure of toe transfer must be explained to the patient when both the thumb and the toe will be lost. And scars will be present on the contralateral foot, groin, and the thigh. Now, 5 things I need to talk about to the patient when you're doing the counseling is, I will talk to him about the different options that are available. Once the plan is decided, I will talk to him about the time frame and how it suits him because once I do the groin flap, I need to have a minimum of 3 months for the flap to get soft and supple so that I can plan my toe transfer. And the patient must also be prepared mentally for the toe transfer, and he should be ready to accept the complication. I remember we had a patient, young man, who wanted a toe transfer. He actually came to us asking for a toe transfer. We counseled him, and then on the day of surgery, we counseled his parents too. On the day of surgery, just before I went into the theater, I called him again and told him this is what we'll be doing again. And I just told him, don't worry, everything will be okay. His mother came to me and said, "Doctor, will it work completely?" So I realized that she has not understood that there is a chance of a complication. So I told them, I will not be doing the surgery today. I told him to convince his mother about the complication. She is expecting 100%. Please tell her it will be only 90% in my hands. So the 10%, if she is able to accept, I'll do the surgery. Even though the patient was convinced, I wanted his caretaker, his mother, who is an important person in his decision making, I wanted her also to be convinced. They were convinced. After a week, they came back and we did the surgery for them successfully. Now, next, we need to talk about the complications that can occur at each stage. It is very important that we stress on these. And then the need for increasing number of surgeries. We have planned 4 stages. Sometimes it may be needed to do more amount of surgery. We may need to include 1 or 2 surgeries. For instance, if you do a toe transfer, the toe, as you know, the toe has got the habitus like this. It will not look nice if the toe is like this, the thumb is like this. So this may have to be straightened out. That may need a surgery. We are not sure. We'll have to assess it afterward. This must be counseled to the patient. Not talking to the patient about all the problems is the cause for lawsuits, as I said that day. And at the end, what will be the expected result and the fixed post of the thumb? The patient should be, sometimes what we do, even this was discussed in the WhatsApp group about the training flange. What we would do is we would fix a POP on this side, a fixed POP like a thumb, and ask the patient to move the fingers towards and touch that POP. We call this a training flange for the thumb. And patient must understand how his thumb is going to behave. So that was the discussion about the amputation thumb. We had a lot of discussions, and I'm also open for discussion. There are different answers, different ways in which it can be done according to the decision, according to the circumstances. Now, the second case, that is the discussion of the case today morning. A young agricultural worker presented with swelling on the right hand, specifically on the ring finger, and inability to flex the ring and little fingers. And this has been present for 3 months. The movements available are shown in the video. Now, this is these are the pictures. You can make out a very gentle, small swelling, almost spindle shaped. And this is the movement that you can make out. There is a restriction of movements on the ring finger, and little finger is almost no flexion. So now this is any swelling. So we did the investigations and found that the MRI shows a typical soft tissue swelling of the ring finger, extending throughout the ring finger, extending up to the palm and even up to the distal forearm. And the remark was to rule out a flexor tenosynovitis of the right hand. So, questions. What will be your working diagnosis? Do you want to plan operative treatment or non-operative treatment? How would you proceed? And what do you expect to find if you explore? What will you concentrate on during the follow-up? Now, this had also invited good discussions, and most of people were able to identify the problem as most probably a tuberculous tenosynovitis, because there is no acute symptoms, there is only a restriction of movement and a slow growth of the swelling, and it is spindle shaped involving the entire finger. So this is the findings on surgery. We found you can make out that you can make out the entire the sheath is involved with this sort of granulation tissue. We did not find the melon seed bodies that are typically described in tuberculous tenosynovitis, but we did find some sort of granulation tissue. And when we excised all that, this is the superficial palmar arch. We had to excise the entire pulley system of the finger. Here you can even make out the joint capsule or the metacarpophalangeal joint. And here it is, as I had suspected, it was going into the distal forearm. The entire tendons are bare, both the ring finger and little finger. Involved. So now we have excised it. We were very worried because we have taken away the complete pulley system, and on the table we were able to make the diagnosis of tuberculous tenosynovitis, and this was immediately post-op after suturing. So then we put him on rigorous physiotherapy and on anti-tuberculous treatment. And this is the post-op picture showing the healing of the wound. But what about the movement? What happened? We expect a lot of problems because we have removed the entire pulley system and even the carpal tunnel. If you note this, the flexor retinaculum we had to open up. I almost excise it because that was also involved. But we suspected a tuberculous lesion, so we were planning to start him on anti-tuberculous therapy. The biopsy report showed just as we suspected tuberculous involvement, and we put him on anti-tuberculous immediately. So what was the movement? So this was the movement at the end of 2 months. So he was able to get good movement in the little finger, but the ring finger, there was a deficit. You can make out the deficit there. You can make out the deficit. There is a deficit there because of the total lack of pulley system. Whereas in the little finger, we were able to take away the pulleys only up to the A1 pulley. A2 pulley was intact. So surprisingly, we got back full movement in the little finger, but there was a deficit on the ring finger because of the complete loss of the pulley system. So now, having discussed about the patient with the tenosynovitis, we come to the quiz question. Before we take questions and discussion about the patients, about the presentation, the quiz question of the day. What is this procedure that is shown and who described it?
Burkhalter.
Yes, what is the procedure?
Burkhalter transfer of the EIP, sir.
Very good. For
opponent's plasty.
Very good. So Gijo, good. So transfer of the extensor indicis proprius, and this was described by, you know his full name?
No, sir.
Okay. So this is the extensor indicis operans plasty described by William E. Burkhalter. And is he alive?
Yes.
He died in the year 1992. And he described this procedure in 1973 in American Journal of Bone and Joint Surgery. And because he described it as using the extensor indicis proprius around the other side of the forearm and for opponent's plasty.
Yes.
So good, you've got that right.
Yes.
So, any questions?
Dr. Jordan has a question.
Yes, Jordan.
Hello.
Yes. Yes, Jordan.
Any other questions? Yeah.
Sir, Jijo here.
Yeah, Jijo.
Sir, in the X-ray, the first metacarpal base is still there, no, sir, for the first case.
Yeah, I know. You had discussed about the first metacarpal base. I'll show
Yes,
you.
sir. So,
Yeah, I'll just show you.
okay.
We'll see it again. No problem.
Okay.
Yeah, can you see this?
Yes.
Now, what you are having there is very little. There's just a sliver of bone. Okay, even that is
Okay.
doubtful. Okay,
Okay.
what you are
Okay.
having here, this is the trapezoid,
Trapezium, yeah.
and this is the trapezium. Okay,
Yeah.
this is the bone that is articulating with the index finger metacarpal. So, when you have this, you don't have a CMC joint. What we need to have is a CMC joint, a joint anatomically intact. Then
Okay.
we were discussing about doing an opponent's plasty.
Right.
That
Yes, yes.
is to be done when there is a CMC joint anatomically. If
Yes.
there is no joint, we'll go for only fixed post.
Okay. Right.
Sir, Raghuram here, sir. I have a doubt, sir.
Yes, Raghuram.
Sir, you mentioned that when you took the toe for transfer, you took the contralateral toe.
Yeah.
So, is there any will there be any difference if you take the ipsilateral toe or contralateral toe, or there's any advantage if you take the contralateral toe?
Yeah, there is no hard and fast rule that you take only the contralateral toe. You can take the ipsilateral toe also, but there is one slight logistical problem. When you take the toe, the blood vessel comes on the medial side, right? So when you bring it here, the blood vessel is going to come on the medial side here. When you take in the contralateral side, the vessel will come over here to the radial artery. That is where you're going to put it. It doesn't make much of a difference, but it's more comfortable when you take it from the contralateral toe. Whereas when you do a wraparound toe from the big toe, you usually take it from the same side. For the same reason, on the big toe, the vessel comes on the lateral side. For the second toe, it comes on the medial side. Just to make sure that the alignment of the vessels is more comfortable, we take it from the contralateral side for the second toe.
And sir, one more doubt. Sir, you told that you will fix the metatarsal into the radius.
Yes, into the radius. See, that is, you do not have, there is the point that you are coming here is, you are coming to the lower end of radius over here. Beyond the lower end of radius, you've got the trapezium bone, right? And then you have the metacarpal. Here, you have just a little bit of trapezium there, and there is no carpal metacarpal joint. So here what happens, when you try to fix it, either you can fix it to the trapezium, which is not a very stable bone, or you can fix it to the radius. When you fix it to the radius, the union is much better. You are taking a transmetatarsal toe transfer. That is, you are taking it at the base of the second metatarsal bone. So there is a raw area there. So when you fix it to the radius, it is a more fixed, the union is better. If you fix it, now the other what is the other option? Where can you fix it? You can most
To the
probably
carpus.
to the trapezium.
Yes.
Now
Yes.
trapezium is not very stable, so it is better to fix it to the radius.
Okay,
And when you fix it, make sure that it is kept in a position of palmar abduction. The position is very important because it's going to be fixed, it's not going to move. And the most comfortable position, that is the useful position for movement, is the palmar abduction or the glass holding position. You know the glass holding position where the thumb is in palmar abduction.
Sir, I have two questions, sir.
Yes,
Hello?
Christina.
Sir, my first question is, in cases of acute traumatic injury, suppose we see a nerve, it is not a full transection, but it is very badly contused, that requires a debridement. So in such settings, if in the acute stage itself, is it advisable when, if required, to do a nerve graft? Or is it necessary that once we see the pouting ends, can we go for a nerve graft straight away in the acute setting itself? And my second question is, sir, in case of delayed cases which are presenting with median nerve palsy, how late can we do the nerve graft for a sensory recovery? Like if the patient comes at 5 years or at 10 years, is there still a role for nerve graft in such case?
Yeah. Now, addressing the first question first, you said in an acute injury, if there is a contusion, some of the fibers are intact, but there has been a loss of some amount of fibers. So what I would do in this patient is first dissect out the normal fibers and protect them. You have got the ends that are When you got the ends that are injured, obviously you need to do a good treatment. If the injury has been such that it has caused injury of some fibers but spared some fibers, usually there will be no loss. But however, when you debride it, you will have a gap of about 1 centimeter. And as I said, up to 2 to 2.5 centimeters, you can do a primary repair. So what you can do is you can do a primary repair of those fascicles. Now what will happen to the intact fascicles? Intact fascicles will form a hump deformity. These two will come together and this will be a redundant portion. There is no need to cut the other portion and suture it. Here, when you bring these two together, there was a gap, you brought them together, the fibers that are normal will form a tortuous, they become you have a hump deformity. That is one. Secondly, you talked about how long can we do grafting for. I said that after 2 years, you can do a nerve grafting for sensation. It depends on what is the position of the hand. Are there any trophic ulcers? No trophic ulcers so far, there's no point. However, if the patient is still developing, see, now when do trophic ulcers develop? They develop when the patient is using his hand actively. Only then trophic ulcers. If the patient is not using his, you gave an example of 5 years or 10 years. Imagine a patient with a nerve injury for 10 years duration. How is he using his hand? That's what we need to see. If he is still using his hand, it is advisable to go in and do a nerve grafting for sensory recovery. There is nothing wrong in it. You're not going to lose anything. However, if he is not using his hand and there's no point in getting back sensation. So that can be deferred. Now, why the patient has come to you after 10 years? If the patient is coming to you after 5 years or 10 years, his function is not good, isn't it? So if the function is not good and he wants, then you may have to do a reconstruction of the tendons also if the function is not good. Usually patients do not present for loss of sensation alone. They come for loss of sensation and loss of movement because that is the one that is going to bring them primarily. So in these patients, it is better to do the nerve grafting for sensation. Ideally, it should be done whenever you see them. Whenever you see them, because he's presenting, he's got a problem. So when you're addressing the problem, and the good thing about is, even after so many years, I think the nerve recovery will be good. Unless you can prove me wrong, but I think the nerve recovery, sensation recovery can be good even after 5 to 10 years.
Sir, in the acute stage question, what I meant exactly was, suppose it is a nerve injury with no fascicle, like after debridement, there are no fascicles in continuity and there is a gap of more than 2.5 centimeter. Yeah. And we have got the pouting edge, but there is always a doubt that there may be an extending contusion we will not able to assess. So there is a trend, some studies which shows that you tag and leave and then do a nerve graft in second stage. So is it some people do the nerve graft in the initial setting itself? I am asking regarding that. Okay, then in that situation, primary nerve grafting is ideal. It can be done. We have done it also. Primary nerve grafting. So primary nerve, why we do a primary nerve grafting is, you know the two ends. You can see the two ends. You can see it best at the time of injury. When there are two ends and you cannot do a primary repair, we go to the next step of nerve grafting. Your question is whether we should do it now or later. Why should you do it later? You can see both ends now. You might as well go ahead and do it straight away. Okay. Now, which nerve would you use? Usually you use the sural nerve graft. Here, you can use the other nerves in the forearm, in the same area, regional. For instance, you can use the medial cutaneous nerve of the forearm or the lateral cutaneous nerve of the forearm. How you identify these nerves? Very simple. Just see the subcutaneous veins and along with them you'll get the nerves. Take 2 or 3 cables. You'll need a length of about 3 centimeters maximally. You said it's a little more than 2.5 centimeters. 3 centimeters you'll need, isn't it? So nerve graft of about 9 centimeters will give you 3 cables. You can do it primarily. Why should we think of doing it as a secondary? The only reason I can think of, no, I will not do it today, I'll do it secondarily, is if there is more injury to the tendons, there is a loss of tendon, there is a loss of skin. In that case, my reconstruction will have to be complete. I will not do a primary nerve grafting if I'm going to put a flap cover on top of it, for like an abdominal flap or a groin flap. If I'm able to get a good skin closure, I will do the primary nerve grafting. Thank you.
Does that answer your question,
Yes,
Mosina?
sir. Yes, sir.
Uh, Sir, in the second case of tuberculous tenosynovitis,
Yeah.
why we couldn't do a primary pulley repair also, primary pulley reconstruction?
Yeah. In a case of tuberculous tenosynovitis, there is one more thing that can happen. There can be a rupture of the tendon also. That is the next stage. It goes in for rupture. The tendon gets, as the synovial tenosynovitis keeps progressing, it sort of compresses on the tendon, leads to rupture. Now, supposing this patient had come with the inability to flex the fingers, we have had patients like that. In those patients also, we will not do a primary reconstruction of the tendon. You can see the tendons. The cut tendons will be rounded and lying over there. So this is an attrition of the tendon. There are two conditions, common conditions in which attrition of the tendon can occur. One in tuberculosis, second in rheumatoid arthritis, rheumatoid problem. In these two cases, you may have an attrition of the tendon. Usually flexors are affected in tuberculous lesion, and in rheumatoid, the extensors are affected. In these, why I'm telling you this is, in primary reconstruction is not usually done in tuberculous tenosynovitis. Similarly, the pulley reconstruction also is not done primarily. No reconstruction is done as far as tuberculous tenosynovitis is concerned. Agreed, we are going to put the patient on anti-tuberculous. We know the diagnosis and we know he's going to get better. But generally, we don't do a reconstruction of the pulleys primarily. We do it as a second stage. Now, for instance, this patient who had a very small deficit, for this, even an external pulley, like when you put a ring, no, that itself will suffice. So the basic principle is no reconstruction when there is an acute process going on, when there's a disease process.
Okay, sir. Thank you, sir.
Ravikiran,
Good evening, sir. Thank you for teaching us. I would like to ask regarding Tinel sign, sir. How would you, in what situations do you use? And how, for example, if there is a proximal forearm cut injury and the patient is referred to you after 3 months and underwent surgery somewhere else. So how would you monitor this patient, and do you judge it for any operative intervention? Do you rely it on so much? So that you can plan your operative intervention based on a Tinel sign, just Tinel sign.
Correct. Now, the first thing is, patient has come to me after 3 months. So I'm going to elicit a Tinel sign. If there is a Tinel, I look for a static sign or a progressive sign. That is, if I find the Tinels at the site of injury itself, that means over 3 months it has not grown at all. Okay, so that is an indication for exploration.
Yes,
Second
that is always straightforward. We find it. Yes.
So we'll start with that. So that is straightforward. Second is, you find that there is some growth. It has grown for about say 3 centimeters, and 3 centimeters. If it has grown, yes, that is good. Now the question comes: it is growing, we can wait, and it has grown to the extent that we expected. So that is good. So again, I would wait. So first, static Tinels, I would go in and explore. Next, it has grown for about 3 centimeters, which is what I would expect. Good, I will wait, no surgery. Now, supposing it is equivocal, sometimes he says about 1 centimeter beyond it is there, and sometimes he says it's at the same place. In that situation, I would give the benefit of doubt to the patient. I would explore.
Yes, sir.
If I explore, now supposing, let us assume that the nerve is growing and I explore, right? What I should have left alone, I have gone in and explored. What will happen? I'm not going to go in and cut the nerve. So what I say is, if it is going to be a negative finding on exploration, you find that the nerve appears intact clinically, and you can even stimulate to see if there is any the spread of the stimulation. But if I go in, sometimes even that may be equivocal. I go in and find there's an anatomical continuity, but still I am doubtful. Of course, I would have done my nerve conduction study also. Nerve conduction study also will tell me whether it is growing or not, whether there is a change in the muscles. Nerve conduction study may not help that much. More importantly, an electromyogram. Before the nerve grows into the muscles of the thumb, the abductor pollicis brevis, an electromyogram will tell you whether it is getting reinnervated. The first signs will be the loss of the action potentials will start. So in this situation of equivocal Tinel sign, if it is static, explore. If it is progressing nicely, don't explore. If it is equivocal, I would explore.
Okay, sir. Sir, any instances where you have done intraoperative nerve stimulation and decided upon a
We have
neuroma in continuity?
Yeah. We haven't done much for peripheral nerves at this level. We have done more for brachial plexus to help us. But usually at this level, I don't know it. I never find any good results, any good findings to help me in my decision making.
Thank you.
Hello, sir.
Yes,
Vinod here, sir.
Vinod. Tell me, Vinod, how are you?
Sir, fine. Sir, regarding this median nerve, sir, if there is an injury in the forearm, that is in the middle of the forearm, and clinically the patient has no motor loss, but there is only a sensory loss. And when we explore, if you find a nerve that is, the nerve is like, no, it's not a clean cut, but
Yes.
there is a kind of aberrations. You have answered to the previous question that still you can, if it's able to switch it, you can switch it, there will be a hump. So
Yes.
you go ahead with that.
Yeah.
But the thing is, it is again in the equivocal, sir. It is like a 2 centimeter gap,
Yeah.
and there is only a sensory loss for the patient,
Hmm.
and the nerve is not fit enough to do a primary repair. How will
Okay.
you go about, sir?
Okay. Now you have opened. This is an acute injury you're talking about, isn't it?
Acute injury.
In acute injury, you have opened, explored, and found that there is no motor deficit distally. There's only a sensory deficit,
Yes, sir.
but there is some fibers, fascicles that are cut, isn't it?
Yes,
Now,
sir.
should you repair or not repair? That's your question?
No, you definitely have to repair. How to repair it, sir? Because there is a sensory loss.
Yeah, there's sensory loss. You have got some fascicles, proximal and distal. Is it
Yes,
possible to match the fascicles?
That's what, sir. That fascicles is not a clean cut. There are like it's in pieces.
Yeah. Now, as I said that time, first thing is when you have a partial injury, what are the intact fibers? You first separate them completely and protect them. Now you are left with only the fibers that are injured,
Yes, sir.
right? So
Yes, sir.
you can identify those fibers alone and then see if they come for primary closure, or do you need a grafting, nerve grafting. If there is a gap, even if there is no motor deficit, I would do a nerve grafting, because there is no motor deficit. Patient is going to use his hand. All the more important that you give him sensation. So primarily you can do a nerve grafting. Now the next question I was expecting was neuroma in continuity. Supposing,
Yes,
yeah, I think that's what you also meant.
Yes,
Now, supposing I go in and explore after 3 months and find that there is a neuroma, there is a diffuse swelling of the nerve. Okay, he doesn't have sensation. He has some amount of movements, but it is very unequivocal. And you go in and find there is a neuroma in continuity. It's just a spindle-shaped lesion. What we need to do there is make an incision in the epineurium, open it out, separate all the fascicles, separate out the fascicles that appear intact, and for the remaining fascicles that do not appear intact, we need to cut it and put a graft. We must tell the patient that there may be a loss of some amount of function after this. We do not know. To our knowledge, we will take away the fascicles. We will separate the fascicles that appear intact, because a neuroma in continuity means that exactly what you were saying in the acute stage. Some fascicles are injured, some fascicles are not injured. If it is not repaired, it leads to a neuroma in continuity. There is a spindle-shaped swelling. So you protect the fascicles that are intact, separate them out and protect them, and for the remaining fascicles, do as you would plan for a complete nerve. You put a nerve graft.
Okay. Thank you.
Shalini?
Sir,
So yes, sir, same question, neuroma and continuity.
Yeah.
How do you identify the nerves that are intact and the nerves that are trapped in the neuroma and the nerves that are working? Is it the internal topography, or do you do something?
Yeah, you want to know how to identify the nerves that are intact, fascicles that are intact, that are working.
In a neuroma and continuity.
Yeah, in a neuroma and continuity. See, I told you, you make an incision in the epineurium, proximal and distal to the involved segment. Okay, there is one segment that is bulbous, spindle shaped. Proximally and distally, it looks quite normal. So in that area, open it, dissect out the fascicles and keep dissecting through the neuroma. you will be able to find out the continuity of some fascicles and you will be able to protect them. You still do not know whether the fascicles you have are really intact. They look anatomically intact, but they may also be involved in the injury. So here I think nerve stimulation may help. I do not know because I have never used it. So here it may help. The remaining portion that is definitely not dissectable, that you may have to excise.
So do we think that we might lose whatever there's a possibility of losing here?
Yes, there is a possibility of losing some of the function. That's why I said, no, you have to tell the patient that you may lose some of the function. See, there are some conditions where you may lose some of the function. For instance, in the case of obstetric brachial plexus palsy, you're doing an exploration at the end of, say, 6 months, okay, for the child in the neck, for the brachial plexus. Already some amount of movement child is having due to some cross innervation. If you are going, and it is not, but the biceps is not recovered at all. As we know, the biceps should recover by 3 months, at the maximum by 6 months. If you are waiting for 6 months, there is no biceps recovery. Then you need to explore according to the state of the art. I mean, according to the understanding of the brachial plexus. Now, if by 6 months the biceps is not recovered, it's better to explore. In that situation, whatever little movement has grown due to the cross innervation may be lost. We have to explain this to the parents of the child before we go into the surgery. And as I said, see, what we are doing is only our understanding of science. And patients must be able to understand this. We may be wrong, but this is what we need to tell the patient's attendant, because this will definitely happen. As you say, there will be some loss of movement. That should be explained to them.
Thank you, sir.
So if there are no more questions, can I close the session, sir?
Yeah,
Sir, one more question, sir. Sir, in that case which we discussed, the previous case, if you are doing a toe transfer, how do you reconstruct the lateral band, sir?
Lateral band for what?
Yeah, I mean for the MP joint, sir. I mean, I couldn't get the clarity when I read the traumatic toe transfer cases. Is there a role for reconstructing the lateral bands, or is it totally insignificant?
You're talking about the lateral band of which thing?
When you do the toe transfer, sir.
Yeah.
For the MP joint.
Yeah.
In this case, you mentioned metatarsal toe transfer. You do.
Because there is no. You're going to fix it. You're going to take the metatarsal and make it become the first metacarpal bone here.
Yes,
That's
sir.
what I said.
Yes,
so,
sir.
Where do you want to reconstruct the lateral band?
For the MP joint, sir. The MTP joint of the second toe will become the MP joint of the thumb.
Yes, very correct.
So yes, I mean when we look at the MP joint of the newly reconstructed thumb, how are we going to reconstruct the lateral band, sir?
I think you're talking about this position of the toe. It's going to be flex position. You're talking about that?
No, I mean the basically just like, I mean
you're talking about the intrinsics.
Yes, sir. Intrinsics, correct.
Now, the intrinsics would be needed only when you are going to have this movement. Here, it's a fixed pose. There's no intrinsics.
Okay.
So there is no need. What is going to happen is only the FPL acting through your attachment to the flexor digitorum longus. Okay.
Right, sir.
This movement is not there. The only situation where you need that movement is, as you had drawn a diagram and shown on WhatsApp, isn't it? When you put the metatarsal onto the stump of the metacarpal bone, then you need to do this, what you're talking about. Okay.
Yes.
There, what you need to do is, when you do an opponentsplasty, either, for instance, Burkhalter. Can you do a Burkhalter for this patient? He doesn't have the index finger. This patient doesn't.
Yeah. No, the CMC is not going to move.
No, I'm talking.
No, it's not there. I mean, probably would have.
If the CMC is there and there is a stump of the metacarpal, then you have kept the metatarsal bone onto that metacarpal. So there is a joint. So you need to reanimate that joint. So you need to do an opponentsplasty.
CMC.
So my question was, can you do an EAP opponentsplasty for this patient who does not have an index finger? You can. But the EAP is still redundant.
You can.
Okay. But the only thing is the EAP might have retracted, maybe short. That's the only problem. So when you bring the EIP and do an occurrence plasty, you need to fix it to the metatarsal bone.
Yes.
You understand?
Yes. Yes.
Do a drill hole, and you do, like how we do for any tendon to bone suturing. That is what you have to do.
Okay.
I think that's what you're meaning, isn't it? So for the intrinsic
I was thinking about the polycization in this case, sir, because you transfer the Interosseous to the lateral bands.
Yes, that is a polycization.
Yes. Right.
Thank you.
Thank you, sir. Thank you.
Thanks, everyone, and I'll close the meeting here. Thank you, sir.
Thank you, sir. Thank you. Bye.